This is a very interesting case across the board. First, has a cough. What do? We taped her head. So if she does cough, she can't get too far. 2, we're going to put a toric IOL. 3, she's got very advanced catarrhata. Can't miss them. You'll see them during the case. You can even see them now if I zoom in. I will in a minute. 4, she's got pseudoexfoliation. And now she's fallen asleep, so she can't focus on the light for me to mark her cornea. So I'm using a cotton tip applicator in the medial canthal region to center her eye so that I can then bring the toric axis marker in and mark her at 160 degrees. So that's the axis that I want to put the IOL. So in dealing with eyes with advanced catarrhata, she has no endothelial cells visible. None on her endothelial cell count. And she's just waking up and talking to us a little bit there.
That's what everybody pointed that out.
Okay. So what we want to do is protect her endothelium, every single cell if we can. And how are we going to do that? Let me have that cotton tip applicator again. Not quite enough room in that medial canthal region for my finger. So I'm going to put a cotton tip applicator there to stabilize the globe as I wiggle in the keratome here. So because of the pseudoexfoliation, I want to stain her anterior capsule. Here comes air, and then trypan. Because of her endothelial dystrophy, I'll in a moment, after I put in the lidocaine, you're going to feel a sting for a few seconds. I'm going to fill her anterior chamber with viscoat. And by that I mean a real complete fill. From angle to angle, from anterior capsule to endothelium. And happily here, I have a nice deep chamber, wet the cornea. And then I'm going to want to divide this nucleus into a lot of small pieces so that I can remove them far from the endothelium. So let's now center the globe and do the rexus. And as I zoom in here, you'll be able to see these guttata. They're everywhere. And they go pretty far out, like to there. So I'm going to make this rexus around 4.5 to 4.8 millimeters, like so. And then we're going to do hydrodissection with this flat 23 gauge cannula. No fluid wave yet. That means it was just coming out. So I'm just going to move a couple of areas here until I get some kind of fluid wave that goes across. Interesting that it's a little resistant to that, but just keep at it a little. Don't do a hard, forceful injection in any one area. Wet the cornea. I'm going to let a little OVD out and then do it again. Now I'm going to do viscodissection for 180 degrees. And because of the pseudoexfoliation, I'm going to do it actually for 360 degrees using the side port to get the subincisional area. Okay, so now we're ready to do our phaco. So I want to check infusion capacity. Turn the sleeve until it's really good out of both sides. There we go. and then in we go. So that was a 2.4 keratome. This is the ultra sleeve of the Centurion. It's a fairly dense nucleus. I'm going to stabilize the nucleus by putting the chopper out over the equator. And then I'm zooming and focusing. The guittata kind of interfere with the view. You don't get a crystal clear view. And of course OVD with some cortex in it can kind of do the same thing. So now we're probably in a good area. We've gone deep enough to chop. So remember, with pseudoex, we want to take out the first piece as soon as we create it and decompress the capsular sac. And with advanced endothelial dystrophy, quadrant removal, please. And what, the cornea? We want to make pieces small. Now, we've got a lot of markers of OVD here. There's some wispy cortex in the anterior chamber, subendothelial region. And if those things stay there, well then sure enough, we have not removed OVD from the endothelial region. What, the cornea again? Now it's true, they interfere with my visualization a tad. But if I'm careful enough here, that won't really bother me. I'd rather have the stuff there protecting the endothelium. Okay. So now we've got this part of the nucleus. We've removed about half of it. Let me see if we can get this to rotate and chop just a little bit here. So what I'm really doing is removing small pieces of this nucleus. I need you not to talk, honey, so your head will be nice and still. Now I'm just checking to see if I can just move this heminucleus central a little bit and just get it to rotate a little better. Remember, with pseudoex, the zonule doesn't provide a lot of resistance. What, the cornea? So that was a bit of a back crack where I went underneath the nucleus. But this zone right here is not separated from its capsular cortical attachments. So, what, the cornea? So what I'm going to do is I'm actually going to put in capsule retractors here to hold that capsule still. Because if I vigorously try to rotate that area, I could stress the zonule. Okay, keep looking straight at the light. So before putting in the capsule retractors, I'm going to refill this chamber with viscoat, enlarging the pupil as I do so. Okay, so in placing these capsule retractors, I'm going to make little vertical punctures. The capsule retractors that I prefer are the Chang version of the original Mackool capsule retractor. And I'm probably going to put in 4. Now, you can see the patient's head just moved because she swallowed. Imagine how much the head movement would have been if she weren't taped. But we haven't had any coughing issues, so that's good. Okay. So I'm going to put the 4 retractors here in the medial canthal region, and then we'll insert them one at a time. Good. And as we always like to say when using these retractors, their purpose is to just approximate, not to pull tightly on the capsule erectus. So we'll just set it there like that. I'm going to use a spatula here to stabilize globe position while I try to get this one. This is a little tight puncture and I'm not sure. There we go. Got it. And you can see why we stained the capsule to begin with, because you really could otherwise not see it through the guttata, etc. Would not be easy. And those head motions you see are the involuntary motions of movement with swallowing in this patient. Oh, we'll slide the third retractor in here, wet the cornea. Good. Try looking straight at the lights. Good. Just like that. So we got one more to go, and we know we want one for counter traction on the other side. And just keep looking straight at the light. Not a lot of limbal exposure down there, so we may have to do a little bit of finagling here to get this one in. Let me have a spatula. And by that I mean let's identify the location of the puncture. There we go. Spatulas are good for identifying little punctures that may become kind of obscured and tying. Try to keep looking straight ahead, not all around. Okay, I need you to look just slightly up toward the top of your head. Good, just like that. Nice and still, please. Good. Now, when you first begin to put in these retractors, if you haven't done a lot of them, it's not a bad idea to administer a peribulbar, because patient motion can be a little tricky for you to handle. Okay, let's go back to phaco. So, let's go, yeah, quadrant's okay. I may have you go to sculpt in a minute. Okay, so you will, of course, remember that it was difficult to rotate the nucleus. Now look. Let's go to sculpt. What's the difference? Be still, please. Good.
Focus.
The bad news is that is focused. We're looking through the guttata, so it's hazy. So that was an impaled shot, quadrant removal. So the big difference here is that by putting in the retractors, nice and still, honey, we stabilize the capsule. And by stabilizing the capsule, we could rotate the nucleus. The capsule doesn't come with it. If I had persisted in trying to rotate that nucleus, we would have dialyzed some zonule. Wet the cornea. And just make sure there's no nucleus up here. I think it's epinucleus, which will probably aspirate. Nice and still. Your head's moving too much. Try to be still. Yeah, there's some nucleus right here. Let's sweep that little guy out where we can get it. So nucleus is removed now. I see little chips here. Let's see if we can get those. Yeah, a little one there, probably going to come out right behind my phaco tip, or we'll get it with INA. Okay, INA. So now we're going to remove cortex. And we know the zonule here is compromised, so we got to be aware of that as we strip out cortex. But the capsule retractors are protective in that regard. What, the cornea? And we have a lot of epinucleus. And I'm just kind of running the spatula under it to lift it up off the capsule. I don't know how we ever did these cases without capsule retractors. The answer is with great difficulty. What, the cornea? And the haziness that you see, that's the guttata we're looking through. You know, we've got an anterior chamber full of OVD protecting our cornea. And I don't really care if it takes 5 or 10 or 15 minutes longer. The idea here is to do what you can do when you can see well. And if you can't see well, stop and do what you have to see better, while protecting that posterior capsule all the time. So now we've got a little subincisional stuff here, and then we're ready to put in OVD in the IOL. So I'm injecting what, the cornea, the OVD into the posterior chamber, and this is Provisc. Now you can see that this retractor has escaped, although we haven't really needed it. This was the area that we were concerned about, but I'm going to reposition it. And I think it escaped because of contact with the lid, which was kind of inevitable given the motion of her globe. So now we're going to put the IOL into the capsular sac. And remember, it's a toric, and we've got our axis marked there for it. And at the end, we'll be injecting myostat to try to prevent a pressure spike, because we're going to leave OVD in this anterior chamber, that's for sure. Those two haptics are getting acquainted with each other rather well there. We'll separate those in a second. Now there they go. INA. So the next step is going to be to remove the retractors. This one is actually preventing that haptic from sneaking into the bag. So I'll loosen it and get it above it like so. And we'll just leave it there for the moment. Of course, you always want to be sure when you remove these retractors that they're clear of everything. Clear of the iris, clear of the capsule, and then you can just pull them out. So I'm going to rotate this one so that I can then direct it up and out over the iris. And now we've got one more to remove. And this is a Grayther collar button instrument from long ago. And if I can get this into the angle of this retractor, I can pull it over here and then take it out through the primary incision. Notice that I'm elevating so that the trailing part stays away from the endothelium. Now we're ready for INA. And we'll remove the OV that we can from the posterior chamber. And there was a little more cortex there, as you saw. Syringe BSS. Okay, home stretch, just finishing, nice and still. I'll rotate the IOL in a minute now. And the patient was moving there, so I came out of the eye prior to repositioning or positioning the IOL. Keep your hand on her head. I got to move the IOL to 160 degrees. Wet the cornea. And we're getting close there, but got another 10 or 20 degrees to go. Wet the cornea. Okay, just a little bit more rotation. So I'm looking at the dots on the IOL to make sure that they're either on or parallel to the marks on the cornea. A little hard to see the dots there through the opaque capsule, but I think it's just a few degrees too far rotated. So there we go. The dots are right there, and there they are right near my spatula. So now we're right on. Hard to see without the microscope. I can just show you if I tilt the eye that way, you can see those, and I can see the ones on the other side with a little difficulty, but they're right there. Okie doke. So yes, we're leaving OVD in the anterior chamber, but we're going to irrigate the angle. And then a little stromal hydration for the incision. We're going to put in the myostat now. And this again is to prevent the pressure spike as best we can, but we're going to watch her IOP like a hawk post-op. So here's our final view, the pupil getting smaller, the guttata ever present, and the IOL right in the bag. IOPs, even a little on the firm side here. I'd say about 30. And our patient is mobile as ever, but done.